Okay, we are live. Welcome everyone. It's a great pleasure to have our third webinar series on controversial topics in pediatric surgery. And specifically, today we are talking about the treatment of total colonic agangliosis and long segment Hirschsprung's disease. And we have two experts in the field. I'm very fortunate to have Richard Wood and Jonathan Sutcliffe. They have different ways to approach the same problem, and this is what makes it more interesting for all of us. So we're starting with the two presentations, Dr. Wood first and I should say Mr. Sutcliffe afterwards, and then in the meantime, you can post your questions on the chat, and we will then pose your questions to both of them at the end of the two presentations. All right, so with me is Martin Lacher, like last times, and we are starting with, as I said, with Dr. Wood. Dr. Richard Wood is the Chief of the Department of Pediatric Colorectal and Pelvic Reconstructive Surgery at Nationwide Children's Hospital and Associate Professor of Pediatric Surgery at The Ohio State University. So it's our pleasure, Richard, to hear about how you deal with these complex patients with total colonic agangliosis, so long segment Hirschsprung's disease. Over to you.
Great. Well, thank you very much. I'm very grateful to Augusto and Martin and the EUPSA committee for asking me to be involved in this discussion, as well as being able to debate a few topics with my great friend Jonathan Sutcliffe. It's a pleasure to be part of this and a great initiative, so thank you. I don't have any financial disclosures to declare. Augusto and Martin gave us a bit of an outline of the things they wanted us to touch on, and really the areas that they wanted us to focus on were diagnostic workup, the age at which we perform our reconstructive surgery, and our thoughts on postoperative management depending on our treatment options. I have to say, I think there's quite a lot of overlap and between them, whether you do a straight or a DML, but we'll get into that in detail going forward. So with regard to the diagnostic workup, I think the diagnostic workup is essentially the same for all Hirschsprung's patients, although clearly there can be a difference in the presentation for longer segment patients. There is some evidence that they can present later. There's some thoughts that some of the pathogenesis is acquired, and clinically, some of these patients are ones where you suspect Hirschsprung's and they don't do particularly well with irrigations. But that said, I think the treatment is, the diagnostic workup always starts with a suction rectal biopsy. Obviously, your pathologist needs to be aware of the fact that there might not be hypertrophic nerves in a total colonic. There's been some good work by Prem Puri's group to look into this. I think the one concern there is that people can be worried that you've made your biopsy too low. And that's why there are no hypertrophic nerves and you're just in the physiological aganglionic segment. I think you just have to be careful and trust each other on that. But I think that is one consideration you need to think about. So in Columbus, we still do contrast enemas. I know that's a controversial topic, especially in Europe and parts of the UK and Australia. We have found them to be useful. I wouldn't say I hang my hat on the diagnostic length. I think, you always want to have a pathological length, but I definitely think it can aid in your understanding of how your patients are doing with irrigations and their general condition. However, when it comes to diagnosis, I think the approach is always to do a laparoscopic assisted procedure in our hands, and we do a transumbilical full thickness biopsies. And do frozen sections of those biopsies. And the reason we do full thickness, and I think it's important to touch on this, if you don't do a full thickness biopsy, and I know that many people advocate for seromuscular biopsies, but then you don't get to look at the submucosa, which is where the hypertrophic nerves are in the first place. And I think that historical teaching that if you get ganglion cells in the myenteric plexus and you go 5 centimeters proximal to that, you're going to be fine. I think there's some evidence from the Great Ormond Street group, which has come out in the last couple of years, which clearly shows that's not the case. And if we look at this figure from their paper, and you use 5 centimeters as the cutoff, you can see that multiple of their patients had longer than 5 centimeter transition zones. That's something we've seen in several patients here in Columbus as well. So, I would really advocate for full thickness biopsies. It's very easy through the umbilicus using laparoscopy, or you could just use, I know Jack Langer advocates for Hagar dilators through the anus, but for longer segment, that's not particularly helpful. But I think full thickness biopsies are must for the reasons explained. We furthermore do donuts at the time of our procedure of the proximal bowel to make sure that we have circumferential good colon. The Great Ormond Street paper advocates for this because they had 3 transition zone pull-throughs not doing donuts. So I think that's an area which we have better data on now, and I think has become clearer. So once you've done your frozen section, we use a sort of a flow diagram approach to try and make sure that we get our decision-making right. So if it's sigmoid colon, we go on and do a laparoscopic-assisted pull-through. If it's splenic flexure or more proximal, those patients we're going to map and divert with an ileostomy. And if it's in the left colon, you kind of have a few decisions to make. We would try and determine if you need to mobilize the splenic flexure or take the middle colic artery. If that's the case, you want to make sure that your right marginal artery is going to be present because it's absent in some people. And if it's not, then we would advocate for diversion with an ileostomy and come back later. And we find that protocol has really helped us to make the decision-making clear. We're kind of simple one-trick ponies here in Columbus, so we do the same procedure. I think there's benefits with regard to learning curve and people understanding the anatomy. So we do the same straight anastomosis, whether we're doing a long segment Hirschsprungs for colonic disease or total colonic. If we're doing a long segment, we do a laparoscopic assisted Deloyer's derotation. With a straight cholanal anastomosis, and if we're doing a total colonic, we do a laparoscopic assisted ilioanal straight pull through, both Swenson type, full thickness the whole way. Aged surgery, historically, the advocates for straight always focused on kids being potty trained for urine and stool first. We were for urine first. We haven't found that necessary. We did a study here several years ago. We're able to show that with a postoperative protocol, which I'll share now in the next slide, we're able to get patients to about 4 stools a day and heal their perineal rashes within 3 months and usually by about 6 weeks. And so we've advocated for doing the repair much sooner. So we do total colonics between 9 and 12 months once the stool's thickened up a bit, which I think is really what the duomelists have advocated anyway. And for long segment patients, we generally do them at about 6 months so that the marginal vessels are a little bit more robust. And we do that procedure then. So with regard to the postoperative protocol that we use, we have a fairly well worked out protocol, which we did in conjunction with our short gut folks here in Columbus. The things to mention is that we used to start all patients on irrigations at 2 weeks and do those for 6 months. We don't do that anymore and have not found any change in outcome with regard to their rashes. In addition, we used to do Botox empirically on all our Hirschsprung's patients. We have found that did not improve the risks of getting enterocolitis, so we're no longer using empiric Botox. So although the protocol still stands, we have not found that we've needed to do empiric irrigations or Botox and do those for symptomatic patients who are unable to really empty gas mostly and stool in the postoperative period. And as you can see, we do have plans there for nighttime accidents. We sometimes do small volume enemas for that to try and prevent that. Now, there are some patients who you will still need further intervention on, and then we would advocate for working with a gastroenterologist because they have some more advanced medical approaches to help try and slow the stool down further. But essentially, we have found that we can operate on younger kids than we did previously and still get good outcomes with a straight ilioanal. And by 3 months, they are kind of at a place where most duodenal patients would be, kind of mirroring the experience of the Cincinnati group with looking at straight versus J-pouch for UC. Our follow-up protocol is 1 month, 3 months, 1 year, and then annually. We use standardized definitions as per the Rome criteria for soiling and incontinence, and we use patient-reported outcomes measures and PEDS quality of life to try and determine outcomes. So when you look at the literature, there's a couple of single center series which really don't compare different operative types very well, and there's clearly never been shown to be any great evidence of superiority of straight versus duodenal. And the only 2 big meta-analyses in the literature, in the first one from the Prem Curie group, they never even compared the type of surgery at all. And in the second one, there was found to be no superiority of one procedure over the other. So based on the data that's in the literature, I really feel this is an area of equipoise, which means when there's no data, we have to introduce our personal bias. So I guess it's the time of my presentation when I introduce my personal bias. So I've practiced in Cape Town and in Columbus. In Cape Town, we had the practice of doing ilioduodenals for total colonics, Swenson for colon disease, and in Columbus, we do straights for all patients, straight Swenson for all patients. I guess my experience is that there's a group of patients with duodenal where the pouch just doesn't empty well, and those patients are irrigation dependent. So when I moved to Columbus, I started doing straights, and I have not experienced that same group of patients in the straight group. That said, the rashes are a pain to manage for the first few months, so I think you have to set very clear expectations with families. We have had some experience with removing duodenals, although I will say that I think there's a lot of bias if you work in a referral center where you see obstructed patients, and many patients do really well with their duodenals, which was also my experience in Cape Town. But I think if you have a duodenal pouch which is not emptying well and is irrigation dependent, you can make some progress with doing duodenal resection and a Swenson. However, we still have had some patients who require irrigations post those duodenals removals, so it's certainly not perfect. I think based on the fact that there is all this equipoise in the literature, my personal bias is to continue with straight ilioanals because I believe we can manage the rash and we don't have those same irrigation-dependent patients that we've seen. But I do feel like there's a need to add to the literature, and so we're currently involved in a study with both Cincinnati and Toronto to try and compare outcomes of relatively high volume centers, Toronto doing duodenal and Cincinnati and Columbus both doing Swenson, and hopefully that will add something to the literature to try and answer the questions. So at this point, I'd like to say thank you very much for the opportunity to speak. I'd obviously be open to answering any questions and would like to hand back over to Augusto.
Thank you very much, Richard. It was great. I've got a lot of questions to ask, but I'll pass it over to Martin, who will introduce Jonathan.
Happy to introduce our second speaker, Mr. That's for those who don't know, in the UK, that's better than doctor, actually. It's Mr. Jonathan Sutcliffe. He's a consultant of pediatric surgery with a special interest in lower GI surgery, including Hirschsprung's disease. And he's a real expert in the field and also an expert in doing the duodenal procedure. Yeah, he's coming from Leeds Children's Hospital. And he's a friend for years also in the CTO and on the colorectal conferences. Jonathan, we are happy to have you with us tonight and looking forward to your contribution.
Right, so yeah, really appreciate the invitation, and thanks also to Richard, that very nice talk, very clear. And as you said, Richard, the aim really was to chat through our institutional experience and our own experience with looking after patients with this difficult condition. First of all, as you mentioned, we were asked to talk about diagnostic workup. As you said, some patients come along with a strong family history or they're syndromic, and you think they're likely, if they have Hirschsprung disease, to have longer segments. We all know also that some patients have delayed diagnosis, and for some reason, patients with longer segment disease do seem to present like this. And I wonder whether or not their spastic segment is a little bit less spastic. I've often wondered why that would be, and wondered whether or not actually there's more than one type of Hirschsprung disease with different degrees of spasticity. And then finally, the sort of wolf in sheep's clothing, as you might describe it, are the ones that present just as normal patients with Hirschsprung disease. And they would be the ones that just get under the radar. We're going to talk about those in a minute in terms of what do you do on the table if that scenario develops. Contrasts. So contrast can be useful particularly in classic segment, just as a piece of the jigsaw to help focus your mind on where you're going to be doing the pull through, and perhaps chatting about the procedure with the family or setting the case up in terms of how long you're likely to be. But we know that it's not a good enough test, certainly not diagnostic, for Hirschsprung disease, and it's not a good enough test to exclude total colonic disease. It's so easy to try extra hard to find a transition zone that actually you can make mistakes. And there's some good evidence that you make a mistake as often as you get it right. So we do use contrasts in my centre, but I wouldn't rely on it to confirm or refute long segment disease. This thing that you read about in the literature about a foreshortened colon, that's not something that we've seen. And the other thing that I think I agree is worth flagging is the issue of rectal biopsies. The thing that I'm interested in here is there are good data that suggests that the longer the segment is, then the more likely you are to have non-hypertrophied nerves. That means nerves that are closer to 40 microns. So the shorter the segment, the classic segment, often have micron thickness 600-700, that type of thing. But actually, for the ones that are longer segment, it's much closer to 40, and sometimes it's below 40. I don't understand why that would be, but it has caught my eye over time. Moving on, if you have a child with failed washouts and you take them to theatre to provide a stoma, we're not going to debate too much whether or not this needs to be an ileostomy or colostomy, although we tend to go for an ileostomy. Completely agree with the plan to do a full thickness biopsy specimen. We've had problems in the past. We've done 360 full donuts for Hirschsprung disease at the definitive pull through for a while, preceding my time. But we found through doing that it's really hard to interpret the myenteric plexus. So all the data that are published are on the submucosal plexus, which is why you really need to do full thickness. The site of the biopsy, your biopsy strategy, well, that can vary. Obviously, use your common sense. You need to take a biopsy from dilated bowel. But the thing that I really wanted to flag here is that one wouldn't use the appendix as indicative of long segment disease, because it's clear you can have agangliosis in the appendix, but actually you've got normal innervation of the cecum and ascending colon, so it can give you a false positive. The other thing is, if you're going to do a dermal, you obviously need to do a pouch, and if you're going to do a pouch, you want to make sure that you don't form a pouch in a bit of bowel that will include the ileocecal valve. Obviously, it would damage the ileocecal valve if you got too near it with your GIA stapler. So it's sensible to take your biopsy just outside the region that you would use for your pouch. So 8-9 centimeters, something like that, which actually in a baby will be pretty close to the hepatic flexure. And then finally, the other thing that I tend to do if there's a colon full of fluid when I'm doing biopsies is make sure I suck it all out, because I don't want it stagnating there for a while whilst I'm waiting to bring him in for a definitive procedure. The ileostomy itself I won't focus on. There's discussion about whether it should be loop or end, and as I say, we always take a full circumference. We might come on to that. The other scenario that one would try and avoid is this one, where you have an unexpected finding once the pull-through's been started. What you really want to do is avoid, if you're going to do a dermal, you want to avoid being in a scenario where you've started the rectal dissection, because you're committed then. You can't then park and wait. Once you've done the rectal dissection, of course, you can't do a dermal because you need the rectum. So the age, over the last 10, 12 years since I've been a consultant, the age has changed, came down from 4 years. But actually what I quite like is the idea that what we're trying to do is protect the perineal skin. So applesauce consistency makes sense. We don't eat a lot of applesauce in the UK, I guess, but we all know what that means. 9 to 12 months seems to be about right. And obviously it depends on the length affected. If you've got if you've got long segment disease and short bowel, then that will be different. And it may be that you never get to do the pull through. Presence of Hirschsprung's enterocolitis is obviously important. That affects stool consistency. Just briefly, if you do have a long-term stoma, you need to consider when to remove the redundant downstream bowel, because that might produce Hirschsprung's enterocolitis, may produce adhesions and make a child unwell in of itself. Tips and tricks for on table. Before we start, we always make sure the families know that we are willing to send a message out every hour or two, just to let them know that the child's stable and roughly how things are going, but it will be a simple one-way message. Now, that's not just trying to look after the family for obvious reasons. We find that it improves the whole mindset of the family. When you talk to them afterwards, it's a lot easier, and it means you can then get on and manage them over the subsequent weeks and months a lot better. It really does seem to have a disproportionate effect. Incisions, you can do it laparoscopically. Jack Langer does it through his ileostomy incision. For long segment disease, you could use a midline, and we prefer to use a Pfannenstiel. We think that gives good access, and we do a 360 biopsy. Staple direction, we always put the stapler on in an orientation that's parallel to the mesentery, which helps you when you do your anastomosis down at the bottom end. When you put your first few stitches on, you get to put it on the apex, therefore, the staple line. So that's what we do. Avoid a twist. It can certainly happen. Using Lone Star pins is certainly, I think, a good thing, but make sure that you don't put them in as far as you do when you do a Swenson. You just need to put them on the sort of anal margin, because you don't want to prolapse the dentate line down, because your sutures will go through muscle, which you don't want it to. Different to a Swenson and a Suave, we generally put our incision, or the cuff length's a lot shorter, and we put our incision less than 0.5 centimeter from the dentate. We actually put it at the dentate, but I know others put it slightly higher. Be careful, therefore, not to put your sutures in too deep and pick up the internal sphincter or even the deeper fibers of the external sphincter, because that will cause pain and lead to obstructive symptoms. Watch out for a spur. We go for 6 centimeters. We don't do a long pouch. We go for 6 centimeters, which is 1/5 of an endo GIA. And we actually trim it down at the front. We go below the peritoneal reflection from above, and we trim it at the front. So there's really not that much reservoir at the front. There is a little. So we don't think we need to do Botox up front, as Richard's saying. We don't generally do washouts or dilatations post-operatively. What we do is we do an EUA at 2 weeks, because that breaks down little adhesions between the staple line, which can lead to a spur. In the pandemic, it's been harder to do that, but it's a lot harder to do on the ward properly, so it's nice to do it under GA. Watch out for a spur later. I personally put a flexible scope in to the pouch just to make sure that I can see whether or not there's a spur. I think it's better than just using your finger, but that's each to his own. The Botox debate, well, actually, people say they use Botox, but people use it in different ways. I tend to aim for the internal sphincter and try and get some of the external deep fibers, and I'd like to learn how to use ultrasound better to guide it. And then finally, chronic enterocolitis is something that we do see. We don't tend to see as much acute severe enterocolitis as I think I've seen previously. We use vancomycin, and it's very difficult to prove its use, but my sense is that it does reduce problems and reduces the frequency of acute presentations. Follow-up, I think the key is a goal-focused, systematic approach based on core outcome data sets, being clear that the people we work for, predominantly patients and their carers, tell us what the key outcomes are that we should go for. And you need good informatics support to collect data prospectively. Not every centre has got that. We struggle to get that. We are lucky because we've got nurse specialists, and I think a lot of people on the call will have those. I really value those. I think it's very, very important. And then finally, along those lines, we need clinical psychology input for some of these patients, because we know that the outcomes can be pretty challenging. I know Richard's got a service that says whole of life. It's really important. We've got to make sure that things work properly for them at school and when they go out on play dates. We've got to make sure we collect proper outcome data with regard to continence in amongst all the busyness of our lives. We've got real problems sometimes with some patients with constipation, and we do use suppositories sometimes. Transition is an important thing. We're not clear whether or not all patients should be transitioned or not, and we're starting to think that probably only the ones that we are clear have problems should be transitioned into our adult services, and thinking that we should write a letter with a summary of their care to the other ones that seem to have gone well. So as Richard says, if we're saying what's better with Swenson or Dermel, very limited data, and the data have to be real world and applicable to your centre. Most centres do the same sorts of numbers as we do, and actually a lot of the data come from much bigger series, and I think that's an important thing to set up. Actually, I think that the issue is that we don't properly understand the physiology of Hirschsprung disease. And so it may be that neither operation is ideal, and it may be there's a bit of work to do there. It's a bit like comparing apples and oranges when you're comparing Swenson and a Dermel when you're trying to arrange a barbecue. Maybe we're focusing a lot on a specific area, but there's a bigger picture. Redos cause cortical scars. They're difficult to do, I gather. Now, we've honestly not had a lot of redos to do, but we know it happens. And I think the key is getting the pouch size right. Thinking about spurs avoids you having to do a big operation, and looking after that pouch and keeping it empty. It's possible that Dermel patients are a little more obstructive. Whether or not that makes a difference in long segment disease, it probably doesn't. Richard and I chatted about that recently. It probably doesn't make a big thing. I think what does make a big difference is what works best in your or your institution's hands, including the outreach nurses, what they know. But actually, how do you know what's best for you? Because we only have one life. So there we are. Known unknowns. We got some idea about what matters most to patients through core outcome data sets, but they're imperfect. Here's a very good paper I recommend, which gives you a list of 10 things that matter most to patients. But I think there's a little bit more to do on that. I think we should focus on that a little bit more. And the other thing is, what constitutes functional adequacy? What do you pull through? Well, I don't think 40 microns would really pass muster at the moment if we were to set that. What I want to know is whether or not bowel is functional or not. We've got a bit of an interest here in interstitial cells. And you can see with the graphs at the bottom that there is a difference between disease control. These are children with anorectal malformations having the stoma closed, and Hirschsprung disease from the ganglionic and aganglionic sections in terms of IC distribution for these cells, which are the squeezy cells. But for both, for the proximal section, they are abnormal, and it's same for these cells, which are the relaxing cells. That the bowel that we believe to be histologically normal is abnormal in this context. So that's all I have to say for now, and looking forward to questions. Thank you.
Thank you, Jonathan, very much for this brief and so precise talk on the advantages and honest disadvantages of the dual procedure.
Thanks again. Both very, very interesting, and I really like the how you structured your talks. It's an ongoing conversation. I mean, if we want just to very briefly summarize, I would say that as Jonathan just presented, he does a dual procedure for the long segment Hirschsprungs, whereas Richard does a straight coloanal procedure. And I can kick off right away with a question of mine. What do you do usually for the standard segment, the standard segment of distal colonic agangliosis in your normal practice? Well, the patients that we see more commonly. Jonathan, you do dual for those?
Yeah, we do. Richard's got a pretty interesting and sensible comment on this with regard to long segment Ds.
Yeah, I mean, you know, I think in reality, most people's practices are probably, you know, 10 or 15%, maybe 20% long segment patients, and the majority are going to be short segment patients. You know, Jonathan and I both do the same procedure for all of our patients. We just happen to do a different procedure. But I do think it's sensible to do the same procedure for all of them, because, you know, otherwise, if you say do 10 pull-throughs a year, you're going to do 1 Duhamel and 9 Swensons, or, you know, I think you're better off just doing this, especially when there's equipoise in the literature. There's no clear evidence that one's better than the other. You probably should just do the one you choose to do really well. And I think we definitely do ourselves an advantage of doing the same procedure for all the patients. I mean, one of the main reasons I like to teach the Swenson is because when I've got trainees doing ARM and Hirschsprungs, they're doing a pararectal dissection on both ARM and Hirschsprungs. And so they get much better at seeing that pararectal dissection. And it just means the learning curves get shorter. So I definitely think there's an advantage to doing the same procedure for all your cases. Because if you start doing 4 different procedures, you're going to doing a couple of each every year.
I cannot agree more. I cannot agree more. And it's exactly, you exactly got my point. So I trained in the UK, where most surgeons would do dual-melts. And so I always felt that when you then need to do a dual-melt for a long segment, which is what also I would do, is easier for me than for some colleagues of mine that actually usually do the Suave, but they would then do the dual-melt for the total colonic agangliosis, so for the long segment Hirschsprungs, because of course it's not an easy technique if you don't do it very often. And so I think that the point you raised is really important to try to keep, because we don't see these every day. It's not an inguinal hernia, even though you might be in a very high volume center. But I totally agree with your point. Stick with one procedure and keep doing it regardless of the segment. What do you think, Martin? Do you agree with this?
Yeah, I agree. You should do what you're used to, and also what you know your outcome is. You should not do a straight ileoanal if you think that dual is the better option. If you have good results or fair results with what you're doing, you should stick to it. And I also strongly think that you should not just do a straight ileoanal if you've never done it before. I'm sure there are certain tips and tricks, so you should go somewhere, watch it how they're doing it. And then discuss the pearls and tricks and problems and ways to avoid before you change your technique. I think that's a basic rule. So I was also surprised how consistent your statement were on regarding age. So you both said 9 to 12 months. Historically, it was much older children undergoing the repair. Can you maybe, I don't know, Jonathan first, what made you, I'm sure you experienced the olden days where children were operated later on. What made you go earlier?
We don't necessarily see this directly, but we're influenced by surgical fashion, right? So there are dominant people in the world for colorectal. We listen to them. We all sort of nod our heads, and people say things clearly. 4 years was in my head as I became a consultant as this is what you do. And I thought I was really on it. And then actually, I've had a couple of people I've ended up doing them sooner, and it was fine. It wasn't a problem, but I thought that was just being lucky. And probably over the last 2 or 3 years, I've got a senior colleague who thinks very carefully and he challenges things, and he challenged that. And we were just found we were doing them younger. And then I heard people in meetings saying the same sort of thing. And I thought, well, that's interesting. So to me, Martin, it's probably always been like that. We've probably had surgical fashions change every decade without necessarily noticing it. Maybe this is my first iteration of seeing some of these changes, but I've quite enjoyed watching that.
So my question is, do you have patients also where you did a straight or a DML at that age group and the child could not handle the liquid stools and was stooling like crazy and you thought I should have done it later?
I mean, Martin, honestly, we've had the opposite experience. So I think one of the reasons why we moved younger was because, classically you get withholding behavior in kids with constipation around about 2 to 3 years of age. And we were finding that these kids that were getting rashes were really getting some horrible withholding behavior. In one particular case, we had to put an ileostomy back because the kid had such bad tenesmus. And so in doing them in younger children, we haven't seen the same withholding behavior. And then with using a pretty aggressive protocol of thickening the stool and protecting the perineum, on that protocol that I showed, we've been able to heal the rashes pretty fast. I mean, they always get one. I think a lot of it is about, talking well with the families, doing a lot of support. We're very lucky we have ostomy nurses that help a ton. But I think you have to set those expectations. I tell the parents, you're going to have a perineal rash for 6 to 12 weeks. We're going to manage it with you. It's going to get better, but you got to expect it. But I think the kids do much better with getting that rash between like 9 and 12 months than they do between 2 and 3 years. Because if they set up a pattern of withholding behavior, you really struggle to get them to empty. And that's what we found. So I actually think the corollary is true of what you said, which is that they actually do much better if you do it younger, provided you treat the rash, because you don't set up that sort of dysfunctional stooling pattern, which we've certainly seen in the older kids.
Okay. Thanks for this clarification. Yeah, makes sense.
I was going to ask, do you think that our nursing colleagues have got better or smarter at using different things to protect and actually through Mark and Prof. Pena and people, we really thought about these things, and probably because of that, there's been less withholding as a consequence of just better care.
Yeah.
Good timing also for the standards, because we were talking about fashion, and we try to be more and more minimally invasive, try to operate earlier. Have you changed it during your career, the timing of a pull-through procedure for babies with standard segment Hirschsprungs?
So I think, there's quite good stuff coming out that there really doesn't appear to be any difference in outcome whether you do it in the newborn period or you delay it by 3 months or so for a standard patient. So because of that equipoise, we really try and base it on the family more than anything else. So if the kid's really small, like under 2.5 kilograms, we wouldn't do it in the neonatal period, we'd delay it. And then, if the families are fine to irrigate well and want to establish breastfeeding, we're fine to delay it. And if there are concerns about their abilities to irrigate or their support structures in place or their ability to get to the hospital, then we tend to do the pull-through prior to them going home in the neonatal period. So, I think because there's no clear difference in outcomes between the two groups, I think we're now in a position where we can match the timing to the family and do whatever seems to make sense for them. I think they can bond and breastfeed well either way, but I think, you kind of try and balance the family mostly, because I think the evidence is kind of either way is okay.
There's one question from the floor from Eugene Rudenko, who's asking what's the best procedure. I think we answered that there is no best procedure, but he's particularly asking for a Swenson versus Suave. So could you comment on if you compare those two? You said the Swensons is your preference over Suave, but what do you tell people doing the Suavists? Do you think there's any difference as long as you do the operation right?
So there's one series, fairly historical, which said that the patients with Suave seem to have a few more complications, but again, not great data. I think my comments on Suave versus Swenson are always balanced about how many procedures you're doing a year. Because, as much as I like doing the Swenson, I think if you do it once or twice a year, it probably is more challenging to make sure that you stay right on the bowel and don't damage anything on your way through. And so I think there's a case, I know sort of Yama's definitely spoken about this, where you do a Suave if you don't do it every day and resect the posterior half of the cuff. That way you protect the nerves and you don't land up with obstructive symptoms. I don't think that's an unreasonable approach if you don't have a busy practice and you feel uncomfortable taking on a Swenson with its anterior dissection. I think if you do enough of them, I think the Swenson can be done really safely, and you don't land up with the obstructive issues that we can see with Suaves. I think it's also significant that Jack Langer's cuff has gotten shorter and shorter and shorter, and it now seems that it's definitely about 2 centimeters. And Luis de la Torre doesn't do a cuff at all anymore. So if you're going to do a Suave, you probably want a short cuff. But then if your cuff's that short, are you really protecting the nerves in the urethra? Yeah, they're a little higher than 2 centimeters anyway. So I think there's a case for it if you're going to resect the posterior half and you don't do too many. But I think if you do enough, I think a Swenson's a safe approach. Would be, but obviously I'm biased, but that would be my opinion.
Okay.
Just to chip in the same way that I think the cuff length is an important feature of, not the cuff length, the pouch length is an important component of how you do a DURML. Make sure you don't do it too big. Really make sure about that. I've often wondered, I've worked in places where Swensons and Suaves have been done, predominantly Suaves actually. I think the way you retract transalary is important. I think if you over-retract, I think that probably has a bigger effect on long-term outcomes. And it's hard to measure how much you retract in theatre. So I don't know whether you've got any comments on that.
Questions for Dr. Kumar, and it's regarding the use of cholestyramine apart from oloperamide to thicken the stool in ileostomy and prevent skin excretion. Do you have any experience with that? Any thoughts about it?
No, we use it occasionally. It's generally one of the things that's prescribed by our gastro team, actually. I couldn't say that I've noticed it to be strikingly useful. I've not seen any problems with it.
So we do use it. The one problem is that kids don't tolerate it very well. It's kind of hard to get them to take it. it's pretty unpalatable as a rule. The one thing we have started using is cholestyramine in a paste, because it still managed to bind the bile salts. And so we make a compounded paste as a barrier cream, which includes cholestyramine in it. And that we've definitely found has seemed to help a little bit. So in the patients who can't tolerate it orally, you can compound a paste with cholestyramine in it, which we have found does seem to help. So I think it should be in your armamentarium as an option. I'll do it in conjunction with GI, and you can try it either orally or as a paste. But I definitely think binding bile salts plays a role.
Okay. There's one question from Himanshu Tucker from London, asking the approach investigating a patient presenting with soiling post-reconstruction. Any comments?
Thank you very much. Key thing, first of all, is to make sure we know whether this is rapid transit or slow transit, because the algorithm is very different from one from another. If it's rapid transit, obviously clear. You've got to make sure that there's not been an inadvertent significant injury to the sphincteric mechanism, but also think about motility higher up. If you've got slow transit, you've got to think whether or not there's a mechanical or functional obstruction caused by, depending on the procedure, a stricture or a spur. Retained agangliosis or transition zone will be an important thing. That requires a trip to theatre, an EUA, and potentially a repeat biopsy. Making sure that the family are involved at all steps properly, so that they feel part of it and you're not going to sweep it under the carpet, probably gets you further than you'd expect.
Then there's the question, is there any difference having a long segment with a relatively short gut? So question, any role for a chimera procedure or similar ones in this scenario?
So, sorry, Richard, that's you.
No, I mean, I was just going to say, I think a kid with short gut, you've always got to remember that your primary goal is for the patient to grow and thrive with enteral feeding first, right? And I usually try and counsel these families that, their pull-through is really a next phase in their lives situation rather than worrying, because often they'll be referred when they're really quite young and they're still on TPN and people are talking about, pull-throughs. It's clearly not appropriate at that time to be discussing pull-throughs. So I usually counsel families that, enteral autonomy first, get the kids stable first. And we've seen kids with relatively short small bowel lengths as they get older that have managed to accommodate well, get autonomous, and then haven't really changed our approach and have had good results. But I think your what you want to see prior to doing surgery remains the same. It's just the timing is very different. So instead of being 9 months, they may be 3, 4, 5 years old before they get to that stage where they're autonomous and have accommodated enough to be there. But I think a lot of it is like John was saying earlier, managing the families and explaining your expectations of when you think a pull-through is even worth discussing in these kids. But no, I wouldn't offer a chimera.
We're getting a lot of questions now. One of those is about your experience with cases of hypoganglionosis. This is something that is pretty controversial.
It is controversial. I think the whole area has been confusing for a whole length of time. You remember the INDB discussion, it's particularly important in Germany, I guess. There've been a whole load of other subsets of pathological abnormalities, but the key thing is that we see patients whose bowel doesn't work properly. We see it with our own eyes. The families feel the problem, and we want to try and help them. We try so hard to look at the biopsies and interpret the biopsies into something that appears to be abnormal. But of course, we don't understand properly the physiology of motility. We don't understand the motility. We certainly don't understand secretomotor function. as far as enterocolitis goes. We never even really talk about it. So hypoganglionosis, it's a very difficult thing. You've got to know then the next question is, well, what do you do about it? Where do you resect? Does it improve anything? Minefield, but definitely worth flagging because it shows you've got to get your basic science right.
I think the only other thing I would add is we started looking at colonic manometry in patients where the pathology is not making a lot of sense. And I think maybe there's something there. I don't think we have enough experience to know, but if you've got a patient who's not emptying, well, you might want to see where their HAPCs are ending, because that may give you some insights into what you're doing. Certainly diversion can help. We know that from the constipation data, but post-diversion, you can do colonic manometry in your colonic segment, and perhaps that can help together with physiology to guide us. As Jonathan says, I don't think we fully understand the physiology of this disease anyway, and we're treating a physiological disease with an anatomical solution, which is always, let's say, fraught with problems. So I think in patients where the physiology is even more confusing than it is in the general group, we got to try and use all the tools we can. And I think using motility of both the anorectum and colon may aid us in some decision making, because ultimately it's not about running tests. We got a kid that won't empty and a family that's frustrated. And so trying to kind of come up with a solution for those kids is helpful, I think. But I do also think that, we did a study years ago looking at the quality of life of kids with colorectal disorders, and the worst group by far was the Hirschsprung's patient with obstructive symptoms, way worse than the Soiling ARM or anything else. So I think if there is a kid that's struggling, I think, being reasonable and offering diversion and giving families and children a break is not an unreasonable thing to do, and then trying to get more physiological information and work out what's the next step to a solution, rather than letting them struggle endlessly and developing sort of very negative stooling patterns, which then are hard to break one day, even when you fix the problem physiologically. But psychologically, these kids have had a bit of a rough run. So,
plus, in the era of Botox, we have now different options if you take down the colostomy or the ileostomy in that scenario. Okay, there is another question. Anu Palival asks how many biopsies we need to take in case of total colonic Hirschsprungs if you don't have a clear-cut transition zone. You mentioned already that the appendix is not the ideal site, but how many biopsies do you take and from which sites?
So I think Jonathan touched on it earlier, talking about, your biopsies have got to be strategic. I think doing 5 biopsies in the right colon doesn't make a lot of sense, because you kind of have to think, what are the steps in my surgery that are going to allow me to do different pull-throughs? So, I think splenic flexure is a key point, because that is a decision-making arm. So I think you want to know what's going on there. I think mid-transverse colon is important to get a biopsy of that. And then I think, once you get to the hepatic flexure, if you're still aganglionic, you've got to be cautious, because I think if you have good ganglion cells at the hepatic flexure, you're fine. But if you start getting into the cecal area, we have seen, Jonathan touched on the fact that doing a duhamel with a very short piece of right colon can be problematic. We've also seen kids where they've had a straight pull through, where the ileocecal valve lands up really low in the pelvis, and they struggle to empty because of that. And we've had at least 2 patients where we've had to disconnect the ileocecal valve and re-anastomose it to the top of the rectum or near rectum with a EEA, and then they've emptied well. So I think you've got to think very carefully about pulling down a very short piece of right colon, because it can cause obstructive symptoms just from the shape of the kid's pelvis or from the stapler, as Jonathan alluded to. So we like to do splenic flexure, mid-transverse hepatic flexure, and then possibly one around the level of the right colic artery. And then you're really into the realm of total colonic. I think doing more biopsies than that, I don't think it's really going to change your operation or your operative strategy very much. So that's kind of what I would do. It also makes your pathologist a very grumpy bear if you're doing 25 different biopsies.
And the only thing I'd add to that just to sort of reinforce what was said before about sending full thickness biopsies in formalin for definitive review, and 360 circumference from your stoma if you can manage it.
There's a couple of questions regarding the anastomotic dilatations. Do you always recommend or practice anastomotic dilatations post-surgery? And there's another one saying, is there a role of bulk forming laxative post-operatively rather than doing anatomical dilatations?
So the first one was the anastomotic dilatation. We don't do that. We just haven't needed to, but that's obviously for a dermal because you don't have a 360 incision, if you like, so it's a different entity. And then the second thing is bulk forming laxative use. Now, I was a bit quiet there because I don't think we're on it as much as we could be in terms of dietary manipulation with things like Benny fiber, different types of fiber, soluble, insoluble fibers. And I simply, I don't know how good they are. I've used Benny fiber and that's been useful, but I don't think I've understood the nuance enough to be able to comment properly.
Richard?
Yeah, so with regard to the strictures, we obviously do 360 anastomoses. We always do a 2-layer anastomosis. So between 4 and 8 stitches, depending on the age of the patient, between the seromuscular layer of the colon and the sphincter complex. And then your anastomosis is completely tension-free. It's not really 2 layers in 2 layers. It's really there to hold the pull-through in place. So there's absolutely no tension on the anastomosis. And doing that, we found almost no strictures at all. So we don't do any dilations in the post-op period. We check the patients in clinic. While we were doing the study with Botox, we were doing EUAs. We're not doing that anymore because we didn't find it helpful. So we just check them in clinic with a Hagar dilator and a rectal exam, and that's it. But we don't do any kind of preemptive dilations. With regard to the fiber, I actually think that you brought up the era of Botox, Mark. I actually worry sometimes that we're overusing Botox. I think there are kids with Hirschsprungs, that especially the short segment disease, that statistically thought maybe more than 50% of kids will have some sort of constipation. And I think the problem in the Botox era is we sometimes treating constipation with Botox. Slow transit constipation after Hirschsprung will be better treated with a stimulant, laxative, and fiber for bulk, and really reserving Botox for kids who are having obstructive stooling and difficulty getting their gas out. And we've seen kids that have got, 4 rounds of Botox that come for an opinion, and you just give them a nice strong dose of Senna with some fiber, and the kids don't need Botox anymore. So, I think there's a good place for stimulant laxatives, and I think the fiber definitely helps because it allows you to give a bigger dose of laxative without getting liquid stool. And I think we've got to be mindful that we're using Botox, for what it was intended for, which is, an obstructive internal sphincter that the patient can't overcome. Because otherwise, you never treat the constipation, and then after 3 months, the Botox wears off, the kid's still constipated, and then you do another Botox, and the mom says, yeah, he's pooping better, and then you kind of keep going round and round in circles. So I think we've got to be just a little goal direct, a little thoughtful about who gets Botox and who gets laxatives, because I think they treat 2 different problems, and I think we can muddle them a little bit sometimes.
Our EUPSA honorary secretary from Turkey, Dr. Tupuslu Takent, say, if you have a 3-month-old baby with Hirschsprung and a transition zone at the splenic flexure, how do you do your laparoscopic pull-through?
So the key bit of anatomy, and thank you, it's a very good question. Key bit of anatomy is the MCA, isn't it? It's the middle colic artery. Because if the middle colic artery is going to preclude you doing your pull-through, then you have to, it's a really good question, because you've then got to almost sacrifice a chunk of the colon and rotate it rotate it to the right, and then bring it round. To people that haven't done it, it almost feels counterintuitive. But the bowel just sits better, it works better. So I think that's what the question's getting at. If you've got a splenic flexure that you can't get down because it's just a bit too high, what do you do? And for me, the answer is assess, see whether or not the vascularity is adequate, use bulldogs if you want, see if the marginal vessels are good enough, but it may be that you've got to have in your back locker the potential to rotate it round to the right.
Yeah, I mean, if I can add, so, I mean, we would, in that situation, we've generally done an ileostomy. If we feel that we're going to need to take the middle colic, I'm not very comfortable doing that in a small baby. So if I felt that I needed to take the middle colic, I would probably divert. But then when you come back, which I usually do at about 6 months, basically do the dissection, laparoscopically take down the splenic flexure and take the transverse colon to where the middle colic is. If you're going to do a de Loyer's derotation, as Jonathan described, you always have to take down your ileostomy, otherwise it's going to twist. So then I think you can take down your ileostomy, and through that incision, you can take the right colon part of the dissection, which certainly speeds up the operation, and you can do it through a small incision, which you take down your ileostomy for anyway. I think a very key point to the de Loyer's is you've got to, I believe, cochorize the lateral part of the duodenum, because otherwise when you do the derotation, you can tension, that tissue over the top of the duodenum, and you can see some sort of acquired Lads-Banzi kind of stuff. So we always just take that tissue on the side of the duodenum. Unfortunately, in our practice, we see half of our patients are these and half are short segments. So we do plenty of these. But we found that if you just take down the ileostomy, you can do the right colon, do the cochorization, and then, as Jonathan said, pull it down the right. And you can do that laparoscopically with just a small ileostomy incision. And then you can decide, am I going to close the ileostomy at the same sitting or put the ileostomy back and close it, 6 to 8 weeks later, depending on vascularity, how the kid is, all that kind of stuff. The other thing which I would mention is in the kids that we divert, we get families to continue doing irrigations, every second or third week, just to make sure that distal bowel's emptying. And also so that the parents are good irrigators and the kids have no issues with the irrigations, because I think long segment kids are slightly more prone to getting obstructive symptoms. And so being good irrigators helps. So we do tend to suggest that they continue doing irrigations just to empty all that mucus out of that disused colon. And we found that that's prevented some of the disused colons needing to be resected at a second setting if you land up delaying a little bit. So it's just something to consider.
Okay, great. I think we are done. We are over the hour already. I think it's time to move on with other stuff we have to do. I think that was a great session. I really enjoyed it. We're sharing with Augusto again, and our really very great two prominent speakers, and it's not like normal that they share their expertise and their time to instruct, especially the junior faculty that is watching these webinars, but also very seniors like those who put questions also are interested in those. Also thank Gaia for again setting this up for us and making it possible that it's like live and open to everybody. Augusto, you want to say something maybe about
Thanks a lot, Richard and Jonathan. It was really great. I learned a lot. And again, this is all recorded and available on YouTube. This was a special webinar that was free for all EUPSA members and non-members. We're going to have, again, our webinars only for EUPSA members. So we really encourage everyone to register with EUPSA and become members if they are not yet members, because this is there's great content. Still a lot of webinar series that are happening until at least the end of this year with great speakers and interesting, controversial aspects of pediatric surgery. So thank you very much, Richard and Jonathan. Thank you, Gaia, for setting this up. And Martin, as always, it was great fun.
Thank you.
Thank you. Bye.
So,
Yeah, thank you.